Perfect. We'll get started. I know everybody will jump on shortly. So miigwech and merci beaucoup. Thank you for joining us for our lunchtime health sciences webinar today on lower back pain, best practice assessment and initial treatments. The webinar is being delivered by Michael Poling, physiotherapist. I'm Jenda Baker, and I'm the Programs and Partnership Coordinator for the Health Sciences programs here at NOSM University. And before we get started, we will do some land acknowledgements and welcomes. So today, the agenda will start at 12, and we'll do the welcome and introductions. The presentation will then be sent over to Mike to present on the lower back. And then we will do a question and answer period at the very end of today's session, where you can ask Mike any questions that you may have. If something comes up during the presentation, do feel free to put it in the chat, and I will monitor that throughout the whole presentation. And just so you are aware, this presentation is being recorded and will be posted to our RS and NODIP web pages. All of our previous recordings are available to you on our NOSM YouTube channel. And those links to those recordings are available on our RS and NODIP websites under the resource sections. So in the spirit of truth and reconciliation, NOSM University respectfully acknowledges that our pan-northern campuses is on the homelands of the First Nation Métis peoples. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitaea First Nations and Fort William First Nations. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers and share their gifts with us and teachings so that we may better understand and honor their wisdom and that of all of the traditional keepers of this land. NOSM University will continue to practice reconciliation by listening, learning, and fostering a culture of mutual respect and trust. Michael Poling is our presenter today, and he is a seasoned physical therapist for over 30 years, specializing in spinal care and rehabilitation. Dedicated to helping patients find lasting relief, he treats patients with a combination of manual therapy, exercise prescription, and patient education. He's consulted for numerous professional athletes and sports teams, as well as numerous government agencies. He's been an assistant professor at NOSM University since its inception and works at the Nipissing District Memorial Hospital as a physiotherapist. So merci beaucoup, miigwech, and thank you, Michael, for your time today. We truly appreciate your sharing your knowledge and the opportunity to ask questions. So I'm going to stop sharing my screen and turn things over to you.
Miigwech, thank you. I'm just going to get my screen up here. And thanks everyone for attending today. I always find when I'm introduced as a seasoned therapist, I always think it's the salt and pepper that's in my hair that really is the relevant seasoning, I think. So today, let me get that share up. Oh, sorry, I'm doing the wrong thing. There we go. And there you go. I hope that is up and running there. Perfect, good. Okay, so this presentation is long and it's quite detailed. It's more than we can cover in an hour, but I liked the visuals on this presentation better. So I'm going to skip slides to make it relevant. I understand most people here are physios, and there's also a kinesiologist as well. So please, I want this to be helpful for you. So if there's anything that you want me to skip past, yeah, Mike, we know all this stuff already. Please let me know, and I'm very happy to skip through things. I'm gonna breeze through functional anatomy real quick, just touch on a few things that more for terminology, so that we're all kind of on the same terminology page when we speak with patients, because patients are a very important part of this process with lower backs, especially more so than any other area. Low backs come with a lot of fears, a lot of ideas, and a lot of really bad information. And some of that is information that we see online, and other information is actually bad information that we give the patients ourselves, or the physicians or other healthcare professionals may give the patient, because we may not be able to stay up to date on all the changes that are happening in spines. And I tell my students at NOSM that within 5 years, your knowledge is going to be obsolete, which is very depressing and exciting at the same time. So one of the things I really want to touch on today is how to address the different patterns of pain. And I talk about patterns because that's how we're trying to think about lower back issues and neck issues, to be fair, is in patterns rather than pathoanatomical diagnosis. We can't conclusively say that someone has got a disc herniation that's causing their pain, despite all the information pointing that direction, because imaging will show us disc herniations, facet arthropathies, stenosis, all these things in people who are completely asymptomatic and at severe levels in many cases. And so if we know that somebody with no pain at all can have severe disc herniations and facet arthropathies, etc., then we can't conclusively say that in a patient with demonstrating pain with that same pathology, we can't be conclusively certain that pathology is what's to blame. So we now speak a lot more in mechanical terms in describing their lower back pain, which also takes the threat that they've heard of from information that they've received, takes that threat away, because we'll speak a little later about how patients feel threatened many times with their lower back pain. So I want to just quickly go over the structures here. And what I've done is I've categorized the structures here. The red structures being the anterior structures, the blue structures being centrally located, and the green structures being posteriorly located. And the importance of that is it gets you thinking about, when I bend forward, the red structures are under compression, the green structures are under tension or traction, and the blue structures are simply the pivot point. Okay. Now, when I speak about a pivot point, I don't mean a true pivot point like that's where it's actually hinging. I just mean that that's where the forces are generally neutral. Okay. So when we flex our spine, bend forward, sit, kneel, crouch, those are all examples of spinal flexion. We know that the red structures on this slide are going to be under compression. So that should make us think about what's happening to each of those structures. The annulus, which is in this area here, is a very thick structure. It takes up about half of the radius, so radius being from the center to the edge, half of the radius of the disc. The nucleus pulposus is also under compression, and it acts like a gel structure. In other words, if we put compression on this anterior portion, it's going to move posteriorly. The annulus will be stretched at the back, meaning it will actually thin as a result of that, and it will compress or increase its density on the front. And depending on where that load is, that will determine how much of this disc is going to move. And I'll give you an example about that because it is important. If I place all of my body weight, and it's impossible to do this, so we're just talking theoretically here, but if I were to place all of my body weight right where the arrow is, and I'm hoping you can see the arrow right here, where if I place all of my weight on that part of the structure, how much of that disc is going to move posteriorly? Does any, and you can use chat to answer, or you can just use your voice to answer. How much of that gel is going to move posteriorly if my body weight is on this part of the annulus? Any thoughts? Okay, the answer is not much. And the reason for that is because I'm putting pressure on an area that doesn't have a lot of gel under it. So if I were to push down on that and pinch that with my finger, I'm going to compress the annulus, but I'm really not going to displace this too much, maybe a little bit. But if I put my body weight on this section right here, the front part, the anterior part of the annulus, the anterior part of the nucleus pulposus, I'm going to move a lot of gel posteriorly because I'm right over the gel and on the anterior surface. So that's going to cause it to displace posteriorly. Why is that important? Because when patients bend all the way forward, they will very often report to you, oh, this isn't too bad, once they get there. But in the process of getting there, it will hurt a lot, because in the process of getting there, we're going through the bulk of the annulus and causing it to move posteriorly. But once we're there, we're mostly on this structure here, and the annulus is under compression, but the nucleus will flow back into this space now because we've actually gapped this entire posterior aspect, including the posterior aspect of the disc. So that fluid will flow back in, and we've opened up the intervertebral foramen, and we've gapped the zygapophyseal joints or the facet joints. So when we think about that, that essentially means that when somebody bends fully forward into flexion, they may actually have less pain than they have with a little bit of forward flexion if it's a disc problem. And that's interesting because very commonly when you look at the subjective history of the patient, they will say, oh, it really kills me when I'm washing dishes in the sink, which is only about 30 degrees of forward bending. But then you add in preparing for supper. They're bending forward about 15 to 20 degrees per counter. You talk about if they're at work and they have to do work in standing, patients will say, oh, I feel worse in standing. But what are they doing in standing? If they're a Buckingham Palace guard, then they're standing straight and they're relatively neutral. But the vast majority of people are not Buckingham Palace guards where they're standing straight up. They're usually bending forward to reach for something or cut something or assemble something. And so that little bit of flexion is actually going to produce more nucleus displacement in a disc than it would if they bent all the way forward to touch their toes. So that could explain a difference between what you hear on your subjective history and what you observe on your physical examination. And that also is why your subjective history is so critically important. So the idea of this slide is to get you thinking about what happens to each set of structures. And we talked briefly about the disc there, but the same thing happens to the structures that are in the green here. When we bend backwards, we actually compress those structures and we traction the anterior or red structures. And having that thought process in the lumbar spine is very good. It gets more complex as we look at the thoracic and we look at the cervical spines, but we're not going to do that today because those move not just in the sagittal plane, but they move a lot more in the frontal plane and the coronal plane. So it's important that we sort of understand that the lumbar spine only has about 1 degree of movement per level into rotation and about 2 degrees per level into side bending. So that's really important because sagittal movements are critical in the lumbar spine. And getting back to a sagittal movement, a flexion or extension, is critically important in helping the spine get better. We can involve rotation and side bending as an assist, but generally speaking, we're going to be dealing or trying to deal in sagittal movements with the lumbar spine. I'm going to move on to the next picture here. You're going to hear me talk a lot about discs because they account for 80% of mechanical spine pain. And there's a lot of debate about that. You're going to hear a lot of people saying, well, what about piriformis syndrome? What about sacroiliac joints? Those are the other 20%. When we do clinical anatomy studies, this has happened over and over again for 20 years. It's almost always between 70 and 80% of mechanical spine pain being related to a disc. And I'm going to put the emphasis on related to a disc because there are several things that happen with any injury. And I want to point them out because it speaks to how we think in traditional medicine right now and how we want to think in traditional medicine going forward. So a couple things about the disc. They've got very little nerve supply. The outer annulus is the only part that has nerve supply. So in other words, in a disc herniation that is starting from the inside out, which is the usual method, it usually is the pressure in the nucleus pushing its way through the annulus that creates the tear. So it starts from the inside and works its way outward. There are exceptions to that, but that's generally how it works. You're not going to feel any pain until you reach the outer third of the annulus. So you're going to have to blow through 2/3 of the inner annulus before you feel symptoms. And that's a bit of a problem for us because we're going to see people who've already blown through a lot of this stuff. But there are reactions to that injury, even before pain occurs. We'll speak to that in just a minute. The clinical relevance of that is that significant pain may not be present when the herniation begins. Discs also have no blood supply. They get all of their repair materials and nutrients from the superior and inferior end plates of the vertebrae that they're associated with. So if it's L5-S1 disc, it's getting its blood supply, it's getting its nutrients and repair materials from the inferior end plate of L4 and the superior end plate of L5. Okay? There's no bleeding that occurs in a disc. There is no blood supply to it whatsoever. It's avascular. So that also means that inflammation is not a relevant issue for the disc herniation itself. So anti-inflammatories are going to do nothing for a disc herniation. There are other things that they'll help with that are related to it, but again, not to the disc herniation itself. And the function is based on hydrostatic pressure. So you have to understand how a waterbed works or a water balloon works. When you squeeze a water balloon on one side and the fluid moves to the other side, and you squeeze the side and it moves to the other side, you need to understand that very, very well to understand how a disc functions, because it has no rules as to which way it can bulge. But the facet joints do guide the movement in the lumbar spine, so that helps us out a little bit. And the most important part of that, understanding hydrostatic pressure, is that when we talk about imaging, MRIs, CT scans, they are done in lying. There is no hydrostatic pressure in lying beyond the about 25 to 30% of the body weight that's there just because of ligament tension and gravity. So that means that if someone has a significant disc herniation, it can all but disappear on a lying MRI, which makes MRI a completely useless tool, and I'll say it again, a useless tool to diagnose a lumbar spine with. It's great if you're planning the surgery, but other than planning a surgery, ruling out a tumor or ruling out an infection or an occult fracture, an MRI is useless in mechanical back pain. So patients should not have an MRI if they have mechanical back pain. And that's going to be controversial. We'll talk about that. And that's okay. The sacrophalangeal joints, they account for about 15% of lower back pain. They are involved in the lumbar spine at keeping this lumbar spine mainly into flexion and extension. We'll talk about stenosis because stenosis is not a diagnosis. It's a radiological finding only. And I'll explain that in just a moment. Because the reason it's in with this slide is that the facet joints are often one of the key components that are involved in spinal stenosis diagnoses. I want everyone to just appreciate how many levels of musculature there is in the lumbar spine and thoracic spine and cervical spine. Right here, I'm showing 4 layers. There are actually 6, but I've combined some of the layers just for brevity. But you can see the innermost layer, very small proprioceptive muscles that are designed to guide movement and provide proprioception for balance. Secondary is to assist in guidance of movements and directing movements. Okay, these are going to be some of your erector spinae muscles. And we get into some of the larger erector spinae muscles, as well as some of the rhomboids, serratus posterior, serratus posterior, and some of the other relevant shoulder and scapular muscles involved in the thoracic spine. And then, of course, we got the big muscles, the lats, the upper traps, lower traps, that sort of thing. But it's what I want you to appreciate here is how much musculature there is in here and how deep it goes, because that depth can produce a lot of pain, and muscles are very, very highly innervated, as most of us already know. So musculature is a major pain producer, but it's not usually the cause. Why? Because muscle strains in the spine are very rare. They happen with speed. To tear a lat, to tear an upper trap or a lower trap, that takes a lot of force and a lot of speed. We're dealing with a thick steak here. And if you've ever tried to grab onto a steak and pull it apart, good luck. It's not gonna happen easily. So if in your high-end athletes, certainly it can happen in really high-end athletes. The average person, it's not very likely, but they are a source of pain. So why? Want to delve into a typical disc injury and what happens during that typical disc injury, which will help you think a little bit about why all these things happen and why we get misdirected in our typical medical model here. So let's just start off with the disc is injured here, okay? The nerves only innervate the outer third of the annulus, so pain is minimal. However, protective reactions, there are baroreceptors in there that can detect whether or not that hydrostatic pressure is lost in that disc or is changed in that disc. So therefore, it'll create a protective reaction. And in a human body, there are only two reactions that can happen to something like this. Your body can release chemicals, endorphins, serotonin, cortisol, etc. But that's not particularly protective. Our typical protective reaction is muscle spasm. And anybody who's ever sprained their ankle, hurt their knee will know that. This happens in the back at a higher level because this is the core of the spine or the core of the body, and the body does not like that. It's the main structure of the human body. So it does not like that. So it reacts very strongly. So the muscles will spasm. And anybody who's ever had a calf cramp will know that it is extremely painful. So go back to that picture of how much musculature is in the spine and how deep it goes, and you'll understand that it doesn't just feel like a stabbing pain. It can feel like a deep aching pain. It can feel like a knife being stabbed into them, or it can feel like things are being pulled apart. So many different muscular reactions there. However, that's not the only source of pain. So far, we have the disc producing a minor amount of pain. We have the musculature producing a large amount of pain. The muscle contractions will pull the zygapophyseal joints together, or the facet joints closer together, causing them to rub harder, which can produce facet joint irritation. Now we have a third source of pain. And the facet joints are very strongly innervated, especially by nociceptive fibers. So therefore, they're going to produce another source of acute pain that is very, very strong. Now we have three sources of pain, but we're not done yet. As if that's not enough, by contracting the musculature between vertebrae, we're going to pull the vertebrae closer together, which is going to narrow the intervertebral foramen, where the nerve root exits the spine. That can create nerve root irritation because the nerve has now got not enough space for it to rub. That can result in the nerve swelling and taking up more space, which is just going to exacerbate that process. And now we start getting buttock, thigh, calf, foot pain, right? Nerve roots, especially the dorsal root ganglion, very, very sensitive to both chemical and mechanical pain. Mostly chemical, but also mechanical. So now we've got four sources of pain. We've got the disc, the muscle, the facet joint, and the nerve. And the typical patient is going to go to their family doctor. The family doctor is going to say, oh, you got low back pain. I'm going to give you Tylenol, and I'm going to give you some anti-inflammatories and some cyclobenzaprine for a muscle relaxant. We've gone over the fact that nerves are non-vascular, so anti-inflammatories are going to do nothing for the cause, but might help those zygapophyseal joints and maybe the nerve root. However, we're treating a symptom, not the cause. Patient might go to a chiropractor, and the chiropractor might say, boy, those those facet joints are really stiff. They might go to a physiotherapist. Physiotherapists might say, especially manual therapists might say, boy, those are really stiff Z joints or facet joints. So we'll manipulate those and increase the range of motion. Great. So we've increased the range of motion. However, we still haven't dealt with the cause. We're still treating a symptom. They might go to a specialist. They might go to a surgeon, and their surgeon might say, boy, you've got an awful lot of irritability on that nerve root. I'm going to give you some gabapentin. We're going to give you some Lyrica, maybe some baclofen. So we're going to try to really bring down that overreaction of the nerve. And again, we're going to get some pain relief due to all that. But again, we're treating the symptom. If you hear me being a broken record here, is in just about everything that we do, they may go to, and same thing with every other profession that's out there. They go to a massage therapist will massage the muscle contractions, settle those down. But where do we get to the disc? Because the disc started all this off. So I want to just very briefly jump into a different profession. I want to become a cardiologist. So I'm going to become a cardiologist, and I'm going to be my own doctor, which is foolish. However, I'm going to be my own doctor. So I come in and I talk to myself, which I often do, and it's pathological. So if I talk to myself and I say, boy, I've got left arm pain, I've got tightness in my chest, I'm nauseous, shortness of breath, and my lips are blue. And I say to my cardiology version of myself says, gee, Mike, I'm going to treat that because I'm a cardiologist, and I'm going to treat that like nobody's business. I'm going to give myself some acetaminophen or Tylenol for that left arm pain. I'm going to give myself a nice chest stretch for that tightness in my chest. I'm going to give myself some Ventolin for that shortness of breath, and the nausea. I'm going to give myself some Gravol, and I'm going to give myself a nice shade of lipstick for those blue lips. Now, I've treated every single symptom that I had. I should be feeling great, but I'm going to be dead in an hour because I'm having a heart attack. So in cardiology, all that would be ridiculous, of course. So why do we think any differently in musculoskeletal medicine? Why do we chase the symptoms when we can target the source if we are methodical about things? So I wanted to challenge that modern medical management. It's not so modern. It's very old, actually. It's 80 years old. And we need to change it because we don't do well in that medical model with spines. So this would be a typical route of management for the above scenario. So muscle spasm would be cyclobenzaprine, massage therapy, stretching, heat, and for the physios and kins in the audience here, think about the muscle. What would you do to stretch muscle in a spine? We'd flex them, right? So what's flexing going to do to that disc? It's going to make it worse. That's 80% of your patient caseload. So by flexing the spine and giving them, now the argument will be, but Mike, they feel sometimes really good with the knee chest stretcher bending forward and stuff like this. They just don't seem to stay good. They come back and they're back to where they were again. So, how does that fit in with your hypothesis here? Because what also happens, if we think again, what happens with, remember the red and the green structures? When we flex a spine, yes, we compress that disc and we force the nucleus posteriorly and we increase the disc bulge. But we also open up the facet joints, we stretch the muscle, and we open up the neural foramen. So we provide temporary relief to the three biggest pain producers while compromising the cause. We make the cause worse, but we make the things that are producing the most pain temporarily better until they straighten up. And this used to confuse me as a younger therapist. I would have patients come in and they would be in a sitting position where they would be leaning forward. And I'm hopeful, Jen, can they see me at the same time? I'm not sure if they can actually see me or not.
Yeah, everyone can see you, Mike.
Okay, good. So the position I am in now, patients would come in and they would spend 20 minutes talking to me like this. And it confused the heck out of me. Why would a disc patient, because these were confirmed disc patients, Why would a disc patient sit here and talk to me for 20 minutes if their disc was bulging out and pressing against things? And the answer was, and we found this out with functional MRI when I did some training in Texas, seeing the functional MRI for the first time. We physically watched the disc in a patient who was sitting like this bulge out, and it took 20 minutes. And the funny thing was, is I could always almost time my watch by how long a patient could sit here for, because they would sit for 20 minutes talking to me and then say, hang on, I got to get up. And they get up like this. They put their hands on here. Hang on. And they'd be working their way up, and it would take them about 5 minutes to get upright. And I always thought, why was that? When we watched the functional MRI, it took exactly 20 minutes for the nucleus to bulge from a centered position into a posterior position and create the disc bulge that would create issues. So these patients, when they were standing up, would have formed a large disc bulge, and they were trying to get up, but the disc bulge was acting like a foot in the door when you're trying to shut the door. They can't straighten up because there's so much of the disc bulged into that neural foramen that as they did that, the neural foramen to straighten up narrowed, and there was more disc in there than there was before. But when they were in sitting, they were perfectly fine. And so this is what was really confusing to me initially. But seeing that on a functional MRI really changed that thought process for me. So with these sorts of things, if we can address the source directly, rather than, so in other words, we look at the disc as being the issue and treat the disc. Now, not everything is a disc, and I'm fully aware of that. But right now, I'm focusing on a disc because it's 80% of what we see. So if we address that, then the muscle spasms go down. The nerve structure gets more space because there's not a disc bulging into that neural foramen. The muscle spasms go down, that releases the facet joints. And then we can start working with things once that disc has had an opportunity to knit a little bit and resist so much bulging. Now, people always say, well, Mike, what's going on with these chronic people that coming in and they're just coming in and getting worse over a 10-year period. They just seems to get easier and easier for them for their back to flare up. This is why. What we see here is at the start, the original disc structure is at 100% of its structural strength. Okay, and it will get injured and become, say, we're just picking numbers out of the air here. Let's say it goes to 10% of its original structural strength. And what we do is we work to improve that structural strength of the disc, and we get up to about here, and this is about the point at about 50% of its structural strength where it becomes pain-free again. So the patient has no pain. Well, what do you think most people's response to being pain-free after a while is? Oh, finally, my back's better. I can go and do all those things I've been missing out on, or I got to catch up on all my yard work. But they're only at 50 to 60% of their structural strength. So of course, they get injured again, back down to 10%. And now we start working on things again, and some of this might be through treatment, or it might just be natural history. The disc will heal on its own over time too. But they start building back their structural strength. They get to about 30% of the original. This is 30% of the original structural strength. And they get pain-free again. Well, I'm great now. Great, I can go back and do all those things again. Down they go again, and up and down and up and down. And so this is the episodic nature of what we see in low back. This is what makes people think that they have a bad back, because it gets easier and easier. And by the time they get down to where it says recovery 3, if Saturn is aligned with Venus and the wind is blowing from the east, they get low back pain. It gets weak, right? So anything will create low back pain at some point. It's pretty easy to believe you got a bad back and that it's never going to get any better when you go through this sort of situation. So this is why we see these long periods, and we often will write these people off, and we'll say, oh, they've had back pain for 10 years. It's never going to get any better. They're chronic. It's just not going to get any better. That's not true at all. In fact, my average patient as a spinal specialist, my average patient is between 5 and 10 years with chronic low back pain. And the 95% of them respond to mechanical treatment. 95% of them. Okay. So they're not write-offs. I love these people because they are, when you finally get it and you finally resolve it, they are your fans forever. They love you. And you gotta tell them, well, you know what? Most of the treatment is what you did. My treatment is mostly home exercise in a very specific structure. But that home exercise is critically important because it's what resolves the problem long term. So I always tell them, I didn't do this. I gave you some information. You did it. You made yourself better. So, you know, that this is the thing. I'm going to skip past some of this imaging just because of timelines and things like that. I want to get to some of the more meaty stuff, but suffice to say that MRIs, CT scans, X-rays are not important unless there's been trauma, unless there is hard neurological signs, or there is something that is very, very unusual. If your gut is telling you there's something unusual, listen to your gut, get an MRI, no problem. But if it's just that they got back pain and they're just not getting better, that's not a cause for an MRI. Back pain is almost never a cause for an MRI. So what we tell them when they are demanding an MRI, we don't say no right away. We tell them that, hey, it's in a lying position. Most of your pain is not lying. Most of your pain is when you were doing things. That's not going to be captured on an MRI. The second thing is like I said before, most people do have findings in an MRI. The average person has 3 to 5 findings on an MRI. So that tells us absolutely nothing. The cost is a factor. It's not really important to the patient. So I don't usually talk about patients, but what I do say to them is this example right here. If you saw a house and you wanted to buy it and it was beautiful, perfect house for you, would you buy it right away or would you have a home inspection? Most people would have a home inspection because you don't know if the furnace works, you don't know if the door's open, you don't know if the sun comes in at all, you don't know if anything works, because function and the way something looks, there's no relationship, and that's nowhere is that more true than in a spine. Okay, I'm not going to go over some of all the research that we've done to confirm that, but here are the main reasons for ordering a lumbar spine MRI. We actually put this on a coffee cup for the family physicians when we opened the Isaac program, which is now the Rapid Access Clinic. We put this on a coffee cup for them, and MRI referrals for lower back pain went down 70% the next 3 years. And our clinical success with patients went up by 10%. So just so you see the effect. But you need to see, these are the reasons for ordering a lumbar MRI. You suspect a tumor, you suspect a fracture, you suspect an infection, or there is leg dominant pain with hard neurological signs. Tingling of the foot, that does not count as a hard neurological sign. Loss of reflex, that is new. Motor weakness, fatigable motor weakness, emphasis on the fatigable, okay, is a hard neurological sign. Or evidence of true cauda loss of control of bowel or bladder. Okay, these are all the non-mechanical spinal conditions. They account for about 1% of all low back pain. Visceral disease counts for 2%. The other 97% is mechanical lower back pain or mechanical leg pain. Okay, just to sort of show you the rundown. These are a small list of red flags. So we need to be able to rule these out effectively and efficiently in the subjective history. Okay, and I'm going to go through these. This was done for family physicians to rule out, but it's important that we understand our red flags. But I'm not going to go over all these because of time. I want to get to the subjective history aspect of things. Bowel and bladder questions are easy to misunderstand, and if your patient is over 70, you're going to get a long discussion about toileting routines. And if you've ever worked in long-term care, you'll know that's very true. So you want to ask it in a private area. Don't ask it in the middle of a gym full of other people. You're not going to get true answers there. You need to ask if there's a loss of control. That is an inability to go or an inability to hold. Okay, it is not, oh, I got to get to the washroom quickly, but I can get to the washroom. I just when I feel that I have to run quickly to the washroom, that's not bowel and bladder control loss. Pooping in your pants, peeing in your pants, that's loss, and that's what we're looking for. Or a complete loss of sensation in where a saddle would sit. Okay, so saddle anesthesia, and emphasis on saddle anesthesia. A loss of sensation there, not a dysesthesia, not tingling, not a kind of doesn't feel right. That's not saddle anesthesia. Okay. Don't ask, has there been any changes to your bowel and bladder function? You will get a 5-minute conversation. Ask things like, have you lost control of your ability to hold your poop in or your pee in? Okay. If the answer is yes, follow it up. Is this only since your back pain has come on or your leg pain has come on? So if it's happened since they had their last kids, that's not related to this. Okay. Use simple words. So since your lower back or leg pain started, have you lost control of your bowels or of your bladder? Have you had any accidents in your pants since your back pain started or your leg pain started? That's the way to ask this stuff, because it's private, it's embarrassing, and they won't necessarily want to be forthcoming with this information necessarily, but you need it. Okay. There are 8 major questions to ask in your subjective history. If you ask these questions well, that's all you need. The 8 questions. So the first thing is you want to determine whether there's intermittent or constant pain. That's a red flag. It's going to help you determine whether there's an infection, tumor, or something like that. Is there any time that you're awake on your best day in your best position that the pain can go away completely, even for a few minutes? And the reason you ask it for like that is they're associating bad pain with how long it lasts. And that's not always consistent. So you need to follow up if they say, oh no, it's always there. And you say, is it, so there's never a time, even for a minute, where you have zero pain. If they say no, okay, it's constant. But you'd be surprised how many times, even in that situation where they'll stand up for the physical exam and I'll say, okay, where is your pain right now? And they'll say, oh, I don't have any right now. And I'll just go, oh, I clearly didn't answer the question properly or ask the question properly. So you need to establish that, okay? Because intermittent pain is mechanical. Constant pain may not be mechanical. A red flag subjective history that you might want to ask, though, is have you lost weight unexpectedly? That's a common one. And you want to determine why they've lost weight if they have. But wording in these questions is really, really important. Sorry, I just have to move. Okay, so here are the questions. Here are the questions. We've already dealt with the second question, but the first question is, where is your worst pain? And you're looking for the leg or the back. And where does the leg begin and the back stop? Buttock. If it's below the bottom fold of the buttock, then that's leg pain. If it's above there, it's typically considered back pain, although some specialists will consider mid-buttock pain leg pain as well. There's a little bit of a discrepancy there, but generally speaking, the bottom fold of the buttock is where we draw the line. Back pain is rarely surgical. Leg dominant pain can be. So that's how that helps you. Is your pain constant or intermittent? We already sort of talked about how to ask that question, but constant pain can be associated with tumor, infection, or occult fracture, whereas intermittent pain is rarely a tumor, rarely an infection. The next one is, does bending forward increase your typical pain? We're biasing that question a little bit, or well, we're not biasing the question. We're biasing looking for a disc problem, mainly because that statistically we know they're just so prevalent. Okay, and we're looking for a directional preference here as well. And we talk a little bit in the rest of this slide about what the effects are. I think everybody knows that we already talked about that. So we already know that bending forward is likely to produce some temporary relief, but overall produce increased problems or increased pain in the back and leg when it's a disc issue. Since your pain has started, has there been any loss of control of your bowel or bladder? So we already talked about that. The next one is, what can't you do now because of your typical pain that you could do before? That's talking about their ADLs and the things that are really what's being affected here. And don't settle for everything. You need to bore down and get into specifics. If you need to use examples, use examples. Bring them down. How is sitting? Oh, sitting's fine. Oh, so you can drive 2 hours and no problem? Okay, great. You can sit for an entire movie. Well, no, I get a little uncomfortable. I have to shift around a lot and stand up in the middle of a movie. So sitting does aggravate you. Okay. So these are things that you really need to delve into and understand when they're talking about their day-to-day activities, what they're telling you is this position makes my typical pain worse or my typical pain less. So what they're really telling you is the mechanics of how their pain is behaving. We just have to learn to listen to that. And then conversely to that, what are the relieving movements or positions? What's the best thing that you can do? Where are you most comfortable? Right? Have you had this type of pain before? Because if it's a chronic issue, then we need to understand that this may not be a really quick thing here. We may be in for a little bit of time, but more importantly, a lot of education, because they've probably been through a number of different types of treatments if they're chronic, and they've had this numerous times before, and they may come in with a lot of biases and a lot of misinformation. Have you had this in the past? And if so, what was it? And how effective, have you had treatment for this in the past? And if so, what was it and how effective was it? You want to know if someone's already done some work on this patient and so had some great results. Don't reinvent the wheel. Steal, beg, and borrow anything you can. Those questions should lead you to decide your physical exam. So we can cut out a lot of things. If there's no leg pain, I can cut down on my neuro exam. I can just do a Babinski and a Clonus. I don't need to do neurological testing for motor power, and I don't need to do a straight leg raise, because a straight leg raise is a great example. A positive straight leg raise is reproduction of their typical leg pain. If they don't have leg pain, you can't reproduce something that was never there in the first place. So there's no point in wasting your time doing all these things, right? So select all the things, and I've got some basic, and you guys I can give you copies of this presentation, so you've got all this stuff if you want. But these are just some things. I do this for family physicians as well, so this stuff you probably all know. So I'm going to move on to repeated movements, because this, for spines, repeated movements is probably the most important thing for me, because having them bend forward once, absolutely useless in terms of trying to figure something out. It's always going to hurt to bend forward the first time. But what happens? How does the pain behave with repetitions on that movement? Okay, so use at least 10 repetitions. If you don't get any changes in the pain, try 20 movements, 30, 40, 50 movements if you have to. See if you can either aggravate or relieve the symptoms. Okay, and that is important in terms of understanding what we want to happen and what behaviors we want to happen. Obviously, pain going down is a great one, and I'm not here to tell you what you already know, but centralization is a key structure. Some of you may have heard this if you've taken a McKenzie course before. This is a critical element of understanding what's going on. Centralization will mean that the pain is moving from a distal area to a more spinally centered area. Be aware that pain increases as it centralizes. So they may have 10 out of 10 pain in their back versus the 3 out of 10 pain they had in their leg. And they'll be like, what the heck are you doing to me? Why is it okay that I have more back pain? And the answer is because we're taking pressure off the nerve root. The harder you press on a nerve, the further down it hurts. So, but that does not necessarily change the intensity of the pain. So it's what we've always told patients. Hurt does not equal harm. We've said that a million times to patients. Okay, this is the ultimate manifestation of that, because centralization does hurt more in intensity. It hurts less in location. So the land area that it's occupying is less, and that's because there's less pressure on the nerve. So it directly speaks, centralization directly speaks how big that nerve, that disc herniation is, and how much nerve compression is on. Okay, so that's how to discuss it with your patients, and there's more details in some of these slides that we can certainly share with you. We already talked about we use flexion extension for the most part. We're not going to worry about, I talked about why we diagnose in a mechanical sense. We tell people, we want to tell people it looks like you have a disc herniation. And I still do. I'm old school. I still tell them that, even though I can't conclusively prove it. But we're trying to get to the point where we can say to a patient, you have mechanical low back pain that's aggravated by forward bending, or you're an extension responder. These sorts of things. That means nothing to a patient, unfortunately, at the moment, but it's the truth. It's the only thing we can actually tell them that is actually true. When you bend backwards, your pain feels better, or when you bend forwards, your pain feels better. They already know that, unfortunately, because they do these movements all the time. Communicating the diagnosis to patients, we try not to pathoanatomically diagnose, but we still do, because patients will inevitably keep asking you to, well, yeah, but what is it? And that's what will happen. So we do use these terminologies. Disc herniation, I break it down in this way. What is a disc herniation when a patient asks me? It's a tear in the bag that holds the fluid of the disc inside. What's a spondylosis? It's just age-related changes. It's some natural degeneration that everybody has. And then spondylolysis, spondylolisthesis, facet arthropathy. These are all ways in which I describe that to patients, and I use real English, not Latin, because Latin scares the hell out of patients. Okay, these are common MRI findings that patients will get their hands on their MRIs. You'll have to define these things for them, and I call it talking them off the ledge, because they get very focused on these things. Everybody, disc bulges are normal. Herniations are common in just about everybody. Disc protrusions are uncommon, and extrusions and sequestrations are rare. So, but disc bulges and herniations are exceedingly common. Facet arthropathies are extremely common. Ligamentum flavum hypertrophy is very common. And when we put those top three together, disc bulges, facet arthropathies, and ligamentum flavum hypertrophies, that is stenosis. So it's a radiological finding. All stenosis means, I'm just going to go to the next slide here. All stenosis means is that you have a small house. If there's only a couple people living in the house, you can still have a small house, and there's nothing wrong with that. But if you have 14 children, it might be a little cramped. So if you have an active disc herniation pushing into an area where you've also got a facet arthropathy and you've got ligamentum flavum hypertrophy, there may not be enough room for the nerve. However, there still might be. It just depends on how big that nerve is and how swollen that nerve is. So stenosis is not necessarily a permanent diagnosis, because if we can move that disc out of the foramen, then the stenosis, even though they have a narrowed canal, the stenosis is irrelevant, because it's not producing any compression or irritability on the nerve root. So stenosis is not always what it appears to be. All right, so I want to go into the types of herniations. Most commonly, we're going to see herniations that are in this region here, called paracentral. But we can also see very lateral herniations that are out the side. And I want to show you how that affects the nerve roots based on where they are, because these lateral presentations are the most complex. Most of you have seen disc herniations before. You've given them a sloppy push-ups, and they've responded to sloppy push-up in a lot of cases, but sometimes they don't. And this can be why. So when the disc herniates, where the block is here, the white circles are the facets, by the way, or the pedicles, if that's what you, if we've removed them all. But when the disc herniation is outside of the nerve root, what they're typically going to do is they're going to lean to the opposite side, contralateral side. The reason is, as I lean to the contralateral side, it's going to unload this nerve, and that will usually produce less pressure here, because as they lean to the right side in this case, it will free up some of the movement of the nerve. All this neural tissue will shift over. Okay. Unfortunately, that will also cause the disc to bulge further over time. So we have to figure a way to get them to be able to reduce that as well. So their natural lean on presentation will end up being contralateral. However, if the disc has managed to herniate underneath the nerve, they may lean towards the side of their pain, ipsilateral lean. That is associated with a poor prognosis because it's hard to get it out of this little area in here. It's often trapped in here. So what we use for these are side bending motions or rotations while they're in flexion, because the flexion allows them to open up the facet joints and allows more rotation than is normally possible in the lumbar spine. So that can be supine lying, supine crook lying with the knees bent, and rotating. And typically we would start by rotating towards the side of their pain. And what that would help do is move the neural tissue. Because of the rotation, the neural tissue will move away from the lesion, but the disc compression will cause the disc herniation to reduce in size. So if you do find somebody with a really unilateral presentation of pain and they're not responding to flexion or extension movements appropriately, you can use rotation of the knees towards the side of pain in a supine crook lying position. So let's say in a patient with left-sided pain, lying on their back, crook lying, I would start with their knees going towards the left side in crook lying. And I would have them rotate in that direction numerous times and see if that effect centralized their pain or reduced their pain. If the behavior was centralizing their pain or reducing the intensity of their pain, then I would continue that motion. If not, I would try the opposite side at that point in time. Okay, now just going to show you a couple more. I'm aware of time when we're running out of time. So unfortunately, there's just a lot of stuff here for an hour. But this idea here is sort of a picture of where different lesions can be and how they may present in terms of pressure on the nerve roots, whether it's the exiting nerve root coming out here at L4, or the descending nerve root that will continue down and not exit to L5. So if we're getting compression here, we may actually have an L5 nerve root finding, but the problem may be at L4. So that's where I tell our manual therapists, always keep in mind that even though you may have findings when you're doing your palpations at L4 or L5 or L3, the lesion may be a level above that, or even 2 levels above that. So that's something else to keep in mind. I was hoping to get to the point where I can show you different types of disc lesions, but I'm just going to show you some quick ones real fast in 30 seconds or less. But this is a typical what people think of when they think of a disc herniation, where it blows through the annulus. But we can also have an interior tear that causes the remaining annulus to bulge. We can have an annular tear or radial fissure, where the herniation is actually in one spot, but the fluid will go along the radius of the fissure and then bulge at a different side. And this is where your rotations can help, because by rotations, you can actually affect the fluid that's compressed inside here. And this is an example of a sequestration where it's blown through, completely blown through the disc annulus, and it's sort of plastered all over the place like blood spatter in a murder scene. This is how I've heard it described. Another plug for staying away from MRIs. MRIs in lying are unlikely to show many of these types of disc herniations. I'm cognizant of time, so I just want to open it up to any questions. I'm happy to stay a little later if people want to. But if there's any questions, I will provide all these to Jennifer, and she can distribute it to you if you like. There's a lot on this presentation that we didn't cover, but such is fine. So.
Thank you so much, Mike. That's a lot of information, and maybe we can do part 2, which would be lovely, maybe next year. Mm-hmm. So does anyone have any questions for us? You can take yourself off of mute, turn your video on. It's always nice to see everyone as well. And again, I'll get that presentation from Mike and send it in the email today.
So I see Hassan has a question. A couple questions. So correcting the lateral tilt first, I would not necessarily do that in standing, as the McKenzie system often asks you to correct it in standing first. I will usually try and correct it in lying on the first visit with the patient, because in standing it can be very painful to correct, and you can't really help the patient if they won't come back and see you because you put them through so much pain. So I try and build that trust with people, and or have a good discussion with them about, okay, I'm going to try this, but this may hurt in this area, and I just need to find out. So that I probably wouldn't do it in standing. I would usually do it in lying first. A second part of the question was, do you think any prophylactic measure can be effective to prevent recurrence? Yes, I do. And what I think it is having a long discussion about how to avoid sitting for extended periods of time. A, extended periods of time is any more than half an hour. And B, instead of thinking about core stability, which we all talk about, and we all have different ideas about what core is, think about what you need to do with that patient. If they are an extension responder, they need more extension. So they don't need abdominal exercises. They need extensor exercises because they need to be more in extension. Conversely, if they are somebody with true stenotic presentations where extension is worsening their symptoms, I would probably do abdominal work. And I would really harp on whatever movement produced pain relief. That's the movement I would strengthen them into, and nothing else. So I hope that gives you. So it's a two-parter basically. That's what I would do.
Thank you. Any other questions? Again, I want to thank everyone for their time today. And Mike, thank you so much for presenting to us. We truly appreciate it. And
no problem.
Everyone, a wonderful afternoon.
And if anyone has any questions, feel free. I'm at the Nipigon Hospital. I feel a lot of calls from docs, physios, chiros. Happy to respond by email or anything like that with any clinical problems that you might have, or if you have patients you'd like to consult on. I'm very happy to do that.